Hello, everyone. Welcome to the Culinary Medicine Interest Group podcast. With us this time, we have Dr. Lucchesi, one of the associate deans and a professor at NYMC. I'll let her introduce herself a little bit more.
Thank you. So I teach in the medical physiology course and in self-directed learning, ethics, and pharmacology. Right now I am the block director for both cardiovascular and reproductive physiology.
Thank you. So we're going to start our discussion talking a little bit about menopause. And the first question I want to ask you is sort of a general overview of what dietary changes do you find are important during and following menopause, considering the known changes in both thyroid and bone health associated with the hormonal changes, and just a general overview of the changes that are associated with menopause, because we do know that it's sort of a tidal wave of change to your body, kind of like puberty.
Right, exactly. And the first thing that I really want to emphasize is that menopause is a physiological process of aging. It's not a disease. It's not a disorder. It's not the curse. It's not the change, and I think many of the things when people think about dietary or nutritional guidelines for postmenopausal or menopausal women, you have to remember the age group they're in. So part of this is just people age. And so, worrying about lipids and salt and having lots of like fruit and vegetables and fish in your diet, that's not exactly specific to postmenopausal women. So what is? Well, the two things that we worry about are, one is a symptom that is very annoying, which is hot flashes or vasomotor flushing. And then the second is actually bone density, which could be a risk factor for developing osteoporosis. So when I think about the two of those, and you think about diet and what specifically is a little more unique to menopause than just normal aging, so the hot flashes, and again, this is a normal reaction to declining estrogen. And there's been a lot of evidence-based medicine where people are recommending every herbal supplement known to mankind. So they'll do black cohosh, St. John's wort, and all of these with the idea that they have some sort of estrogen, phytoestrogen-like effect that should decrease hot flashes. And the problem is that there's been no concrete evidence-based medicine that these supplements work. There's been anecdotal studies or small studies, and then sometimes we have to worry about how the study's done. So if you're taking St. John's wort or black cohosh versus placebo, is there this effect of just, oh, I'm taking something, I'm going to feel better? So the data is basically not supporting that these are effective at reducing hot flashes in the population. Does that mean that it doesn't help individuals? No. So I think part of the other thing to think about is, listening to your patient and being mindful that, there's population effects and then there's individual effects. And if people are very worried about taking hormone replacement therapy, it's not going to hurt them to take regular doses of some of these supplements, but knowing that some of the supplements do have drug-drug interactions that could lead to adverse effects. So what else do they recommend to women? Again, not necessarily evidence-based. I said, avoid spicy foods. So if there's a spice that tends to make you feel a little heat, then maybe if you're having hot flashes, you shouldn't have that. The same thing goes with alcohol. So, I can no longer drink tequila because during my hot flash phase, anytime I had a margarita, my hot flashes would go insane. So, cutting down on alcohol that can exacerbate hot flashes is a good idea. Same thing with coffee. If you find that any of these things, exacerbate the hot flashes, then you should eliminate them from your diet. But there's really nothing that you can take that is, from an evidence-based perspective, is going to make your hot flashes go away. Not even sometimes the estrogen replacement they give you. It can help, but you have to worry about the doses that are given. And sometimes the dose to sort of avoid some of the effects on the uterus or the breast may not be enough to curb the hot flashes. So there's a lot of more of behavior modification, but not a lot of, keep the house at 65 degrees, all year. That might help, but really from a dietary perspective or nutritional perspective, just not enough data. Now for osteoporosis, it's a different story, because there's been studies that have been randomized, observational studies. And what they find is that a diet of naturally enriched calcium products. So, if you're into dairy, maybe that's going to be a problem, but they've suggested that low-fat milk, yogurt, and cheese, things that have calcium in them, have shown to reduce the risk factor of, or reduce the decrease in bone density that you see in most women that are in a postmenopausal phase. So dietary calcium is great. If you're a vegan or a vegetarian and don't have dairy products, then a calcium supplement is fine. And a calcium supplement with vitamin D is even better, because just putting calcium in as part of your nutrition doesn't mean necessarily you're going to absorb it. And remember, vitamin D helps absorb calcium from the GI tract. So even in the absence of a calcium supplement, it is recommended that women take vitamin D, both for their bones, and there's been some data, still a little bit of controversy of whether vitamin D can lower the risk of developing type 2 diabetes. So there's some data that support it, but more recent data are questioning whether or not that this is a clinically observed phenomena, or there was just some flaws in the study.
Thank you so much for such a cohesive overview. And also, I love the reminder about menopause being a physiologic process. But I want to circle back to something that you had mentioned partly in your answer about the fads and old wives' tales in women's health. And especially when we think about, at least when I think about these fads, I wonder why there is such like a richness of misinformation for women in terms of taking care of their bodies. What are your opinions on that?
Well, first of all, I think I don't really know of any fad diet for any condition that works long term. And, so part of your job as physicians is to educate your patients where to find data. Blog spots are not the place. So I did a little of my own research last night to look at fad diets, or what do they call them, cleansers or tonics. And maybe there were 3 what I would consider valid sites. They were from a hospital. It was a peer-reviewed, journal article, but the rest of it was either ads or blogs. And I think what happens is that there hasn't been a lot of clinical studies of menopause. There just hasn't. There was a big study with the HERS trial, and then with the women's nurse study that was done in the late 90s, but that was related to hormone replacement therapy. But there really hasn't been a study of dietary or exercise modifications on the impact of menopausal changes. And there, I really think that the 2 that people worry about the most are the hot flashes and then osteoporosis. So that's where I think when you don't have the evidence-based medicine, you rely on anecdotes. And women have a long history of taking care of women, right? So the midwives, so there was a lot of anecdotal, this worked for me, so, you should try it. And I'm not saying that that's not true, because I think there's a lot of really basic medical principles in some of what we call the old wives' tales. What I worry about is when people start marketing things like cleansers and tonics, Because first of all, we don't know if they're effective. And actually drinking enough water is probably as effective as some of these so-called colonics or detox juices. So yes, there's a celery fad that somehow taking celery juice is going to make your menopausal symptoms disappear. But the celery has beet juice. But really, when you look at the data and what people recommend, it's not based on women in menopause, it's based on aging population. So I have not yet seen the studies that are distinctly related to women. There have been studies for weight-bearing exercise, and that have shown that that does decrease the risk of osteoporosis. But in terms of good nutritional dietary guidelines, when you don't have them, people fill in the void. Some people do it to make money. Some people do it because, it worked for them and they, felt good doing one sort of particular cleanse or tonic. So they think it's good for everyone.
Thank you. I think that was a really broad answer that kind of touches on some stuff that even we've talked about in other podcasts in terms of, fad diets and their efficacy. We'd had a whole podcast on fad diets and cardiovascular disease. And
Right.
it is true that they're often not built on any kind of science, or they're co-opted from something else. Like, for example, the ketogenic diet coming from a treatment for pediatric epilepsy that's now, the
Exactly.
biggest craze
Right.
in the world, that just makes no sense for any kind of metabolic health.
And as
But
one of my favorite comedians, Hannah Gabsey, says, how do we call it a paleo diet? We don't know what they ate back then. They didn't have like cauliflower pizza with, soy cheese. So, I think again, it's sort of like you take a principle that sounds good. So the Atkins, the high fat diet, sounds good, right? Because, oh, you have a little bit of fat and it decreases your appetite, but it also kills your liver and causes non-alcoholic fatty liver disease and a little bit of, you have problems with your, with gallstones. And so, I think you take a one principle that has physiology or biochemistry that's valid, but then on top of that, they then go in and say, oh, I've got the perfect thing. And if a doctor's name's associated with it, for the lay public, it becomes more legit, right? But I don't think I've seen any fad diet that has long-term outcomes. Even the Mediterranean diet, part of the study was retracted because their primary endpoint was not reached. The only diet for cardiovascular health that has shown efficacy long-term is the DASH diet that was put out by the American Heart Association. And it's not, so it's salt reduction. It's sort of part of the Mediterranean diet. And there have been a large cohort studies that have shown that people that follow the DASH diet compared to people that don't actually have a reduction in hypertension and atherosclerosis. So, I think there is, but I don't think the DASH diet, I don't call that a fad diet because it was, designed by nutritionalists. It was endorsed by the American Heart Association, the American Diabetic Association. So it has some validity to it.
So pivoting off of that discussion of different kinds of diets, another aspect I think in particular that we think about a lot as women is our relationships to food.
Yes.
And menopause is often associated with food cravings, maybe not as strange as those associated with pregnancy, but similar. But there's like a demonization of succumbing to those cravings. What are your thoughts in regards to balancing women's relationships with food and happiness during menopause, as well as, like you mentioned previously, their general nutrition?
Yes, so cravings, again, there's anecdotal evidence. Part of it is they think with the combination of estrogen and then a little bit of insulin resistance, there becomes a sugar craving. So, so some people say, oh, it's an excuse, oh, I'm going through menopause, so I can eat whatever I want. That doesn't usually happen from women, it happens from society. So there's this sort of idea that, oh, women are going to gain weight when they go through menopause because they don't take care of themselves and they don't watch their diet. But when you look at, when you think of a hormone that affects nearly every organ and tissue in your body, and now it's gone. And then you have really high levels of GnRH and LH and FSH. And we think of only what they do to the hypothalamic pituitary gonadal axis, but other cells have receptors for these. And a lot of the cells are in your brain. And so, so what we really don't know is how this hormonal changes actually affect things like appetite or appetite suppression. We just don't know. But I think there is this sort of fat shaming that goes along with menopause. And sometimes it actually could be to the detriment of your patient, because what if they're hypothyroid? What if they have Cushing's? So a very good friend of mine had Cushing's disease, but her doctor was like, oh, you gained weight because you went through menopause, you're eating too much. But she had the classic abdominal fat distribution. She had alopecia. She was having some striations, but the doctor didn't go beyond, oh, you're menopausal. And I think sometimes because of that, there's this sort of like, it's almost like women could control the weight gain if they just had a little bit more, rigor and a little bit more stamina. And I think so, rather than looking at it as a behavioral thing, I think it could be partially behavioral, but it could be due to hormonal changes that are happening at the hypothalamic and pituitary axis, and not just like, oh, I'm going to let myself go because I went through menopause.
Thank you. I think that that's a really interesting perspective, and it kind of goes even beyond menopause. Just the idea that your relationship with food and your general health is not like, just because you enjoy a nice snack of chocolate doesn't mean that you need to be fat shamed or that you're overweight.
Yeah,
The reality is that everything in moderation is of benefit to you if
right.
you enjoy it.
And you're exactly right. And that's why fad diets don't work, and colonics and all these tonic things, because it's not a balanced, moderated thing. Now, I've had that relationship with food all my life. I'm Italian. I've been overweight a lot. I eat more than when I'm just hungry. But on the other hand, there is a concept that we don't teach enough, which is obese but healthy. So, you can be have a BMI that puts you in the obesity range, but have a low blood sugar and low lipids. You can be thin. So, people look at you, oh my God, this guy must be so healthy. He works out, he's thin. But that you have the lipid profile of, LDL of 180, or, a fasting glucose of 160. So I think sometimes, looking beyond the body shape, and not just assuming that when you're overweight, you're unhealthy. And in fact, there's some little bit of evidence that I take hope in, is that not morbidly obese, but when you have a few extra pounds and you get older, your ability to fight off inflammation seems to be a little better. Now that's a observation without any mechanism. One idea could be, if the white fat we know has a lot of inflammatory mediators, and maybe there's some sort of balance between too low is no good, too much is no good, but maybe there's a window where having some white fat is actually put you into an inflammatory homeostasis that is more protective. Don't know, it's observation. But we need to look at the science behind it to say, is that really true, and why is it true?
Thank you. That's a really interesting point that we hadn't really thought of, but definitely interesting to explore further. And kind of transitioning now into a different section of questions, I wanted to ask you a little bit about, in the case of menopause, the idea of prescribing dietary change and how it relates to different pharmaceutical interventions. And also, you mentioned earlier the idea of supplements for people that may not get the necessary micronutrients in their diet. And I wanted to ask you also about the efficacy of those against diet, because in some other research that I've put out in our newsletters, the uptake of nutrients from supplements is not always the same as it
Yeah.
is when you have it in your diet, the traditional way. So I kind of wanted to ask your opinion on those things.
That you're exactly right, because what you have to first think of is the actual amount of the supplement in the pill or the lozenge or the filler that they use to make it. And then if you're giving a huge bolus of like calcium or zinc, then you're presenting your GI system with like a dose, one dose. So it's not it's not coming in small amounts through your diet. So diet is always the best. There are vegetarian diets, there are calcium and iron rich, greens that you can eat. So there is a dietary recommendation that the more you can get out of your diet, the less you need supplements. And in fact, like this Centrum Silver, which, is like probably one of the more common old people supplements, it's actually not bad because it doesn't give you like 5,000% of any one particular like calcium or zinc. So you're not like overloading your system that could actually cause some toxic effects. But it's always been the case is a diet and exercise is always going to be the first choice if people can comply. And compliance is part because it's easy to take a pill, right? You don't have to do anything when you take a pill or a hormone or a supplement. You just literally have to raise your arm to your mouth with a glass of water. So that's easy. But I think part of getting people involved in the dietary changes is incentivizing. And how do you incentivize? You teach them how to cook. You teach them how to cook if they are still working and only have 20, 30 minutes a day. Or they're older and like, oh, maybe your metabolism, because your thyroid level begins to go down, that your metabolism is changing. So you may want to do portion control. That even too much of healthy food, if your metabolism is beginning to slow down, is probably not a good thing. But it's not saying, oh my God, everything you've ever done, because I think the research that I have seen, if you tell someone not to do something, what are they going to do? They're going to do it. So even the American Heart Association, who used to say, stop smoking, all low fat diet, don't eat, now what they're saying is like, look, once a week, if you want to have the Big Mac, have the Big Mac. Because if I tell you you can't have it, you'll go for a few weeks, not eat it. And then you're going to just say, I can't do this anymore. I'm going back to my Big Mac. So what they've actually found when they tell people to reduce but not eliminate, it actually is better. They can adhere to the diet better. I think also giving people easy alternatives. If you're not used to cooking with plant-based proteins or with, things that, I grew up in a very Italian home, so carbohydrates was our major, source of a major ingredient in everything. But, learning how to cook where you get all these nutrients, getting recipes, showing people how to cook, getting them involved in social media by maybe having like, best recipe, here's the, my recipe has the most calcium in it, things that make people feel like it's more than just beyond their own little environment.
Thank you so much for that answer. Dr. Lucchesi, you have touched on so many different elements of our medical science curriculum here in your answers to the various topics we've explored. What are your thoughts in incorporating more nutrition education in the medical school curriculum? And how do you feel this can be accomplished most effectively?
Yeah. Well, I mean, I don't think we can make all of our physicians nutritionalists because there's a science to the nutrition and, it's very condition specific. So I don't think that's our goal, but I think we need for our medical students to have the competency of understanding that how the nutrition impacts preventative health and during aging, during natural changes in during our lifespan, but also recognizing when the diet, focusing on dietary changes is important, and then working with a nutritionist or a dietitian, because you guys are not going to have the time to sit and devise a whole nutritional program for someone in your 20-minute encounter with your patient when you're practicing. So, but what you have to recognize, I believe, is when it's appropriate, to send them to a nutritionist and not just say, oh, go lose weight, right? Because that's what we hear. So I think part of our training for you guys is to make you competent in, what are the factors that go into different nutritional diets in general, not, every specific one, but also recognizing that just telling a patient to lose weight is not going to be effective strategy to get them to their goal. So, bringing in other parts of the healthcare team is going to be, and even their family, because when my dad had his first quadruple bypass, my mother was cooking, lovely chicken breast and vegetables and salmon, and she was finding Big Mac wrappers underneath his driver's seat in his car. But she had been engaged with the healthcare team to say, look, all that stuff he likes to eat, can you help us by not giving him healthier alternatives than all the fried food that he likes? And not giving him 12 ears of corn to eat per sitting, only giving him 2. Which I don't think was like saying, oh, my mother was in control of my father's life. I think they were trying to partner with her to help him who had very little self-control.
Thank you. I think that's a really interesting perspective on it, because oftentimes we think as medical students that we need to know everything and we need to be able to be the expert on everything. And it's very true that we just quite often don't have the time to learn everything about it. And if we have enough knowledge that we can have a conversation and know when we need to farm out to the expert, that's perfect for us.
And I think, that is that team, that IPE things that we try to do with you guys. I would love to have someone that's in a nutritional program or a dietitian be part of that, because that's real life to me. And knowing that it's okay to say, I don't have to know all about this. That's part of also, I think, your education as physicians, to say, hey, look, I am not the expert in everything. I wasn't made perfect. God. Oh. But you can also say, hey, but here's a member of my team who is the expert, and we're going to set up a meeting with you so he or she can help you really figure out how the diet's going to best work for you.
Thank you. And I've been getting more and more excited to ask you this question, because I am also Italian, but also Irish. I do want to know, if you were going to present a dish on MasterChef, what would be your signature dish and why?
Eggplant Parmesan. But the way my mother makes it, which is not the normal way. So how my mother does it, we do the normal, you get the really good eggplant and you slice it with a mandolin so they all come out exactly the same size. And you soak them in salt water overnight to get the bitterness out. And then you dip them in egg and then breadcrumbs and lightly fry them, preferably in good oil and not nice olive oil and not the stuff that's bad for you. But then it doesn't stop there. That's just the beginning, because then you use it like lasagna. So you put the lasagna noodles down and the ricotta, but before you put the next layer of noodle, you start putting in the eggplant. So it comes out, she calls it eggplant parmesan, we call it eggplant lasagna, but it's been the family favorite ever since I was a little kid. So that would be my signature dish, with a nice 1 glass of red wine, a nice, maybe a cab, you need something bold enough to take the red sauce. I like a nice Montepulciano Abruzzi, a nice Italian red that can handle the red sauce. It's not afraid.
Dr. Lucchesi, thank you so much for joining us on this podcast episode. John and I have sincerely enjoyed hearing all of your passionate answers, and I think mostly getting the details about your mother's eggplant Parmesan recipe.
Yeah, I could be willing to share that. She's gone now, so there's not that, need to keep it the family secret.
All right, we might hold you to it for a recipe book that we're working on for the culinary medicine, but it might go in the once every quarter kind of section, as opposed to the weekly recommendations for patients with dietary
take
concerns.
The noodles out, okay? We could definitely take the noodles out of it and make it more healthy. But it would
Thank
be
you so much.
fun. You're welcome.